Assessing MRD in blood is an unmet need across hematology, and in fact, in some heme malignancies, having MRD in blood has been a key part of success. For example, CML. The same unmet need has been there for myeloma, and I think that now we have the tools for effective MRD assessment in blood. Not at all time points. I think that at the beginning of treatment, induction, intensification, we continue needing the marrow. But once patients reach a maintenance stage, less intensive treatment, even observation, blood must come in and replace as much bone marrow aspirates as possible. Now, for effective MRD assessment in blood, I think that we need the complementarity, the synergism between two techniques, mass spectrometry and a cellular method. It can be sequencing or flow, plus imaging even. And for sequencing or flow, it was our impression that we needed at least an extra log of sensitivity for effective monitoring in blood. And that is what we have achieved and presented for the first time this ASH, a new flow cytometry method that leverages on NGF, next generation flow, but introduces a previous step of enrichment of circulating plasma cells from large blood volumes. And with this way and this strategy, that is not more expensive, more time or labor consuming, is a small iteration to the method, is allowing us to detect MRD systematically in the 10 to the minus 7 logarithmic range, even in some patients MRD 10 to the minus 8, that is unprecedented using flow in myeloma. And we are showing also in this abstract that MRD assessment in peripheral blood is highly predictive of outcome, and compared to the marrow, it can even be superior and outperform marrow towards the identification of patients with ultra high risk of relapse, because CTC, circulating tumor cells in blood, reflect not only whole tumor burden, but also a snapshot of tumor growth and disease dissemination.